somewhat educational, and also somewhat aspirational, because I think that there's a lot to talk about when you think about endoscopy in the spine. I do have disclosure of being very involved in minimally invasive surgery, but nothing that should be overwhelmingly a conflict of interest here. The first thing we want to start with is what is the definition of ambulatory? And what I'm finding out as I talk to my international colleagues that it is variable from place to place. And even when you look at data sets within the US, there's some confusion about what outpatient or ambulatory means. In the NISQIP database, which is one of our quality databases, is a federal quality database, they have defined outpatient as both lengths of stay of less than a day and greater than a day, which makes no sense at all. And so some of the data that we produce in the country, in our country, is confused by that definition. I think of it as either being an outpatient procedure, meaning the patient comes in that day and goes home that day, or some people might think of it as an observational procedure, and in some countries that is the case where people stay maybe a day or two. And then the third concept is an ambulatory surgery center, which means that you have a separate specialty-specific surgical center, which is not a hospital, where you would do these types of outpatient procedures. And that's becoming a bit more of a growth, had a bit more growth in the US and also internationally. The benefits of that, of course, you can improve your control over, as the surgeon, over the staffing, OR time, process and quality control, as well as perhaps improving income and location flexibility. This is what people in the US would like to see. Okay, so everything else is drive-through. Why can't surgery be that way? And I think it's possible that everybody in the world may think that way eventually, as we become better and better and create more and more minimally invasive procedures that allow us to do more in less time with less recovery. The overall, the definitions, as I said, are very regionalized. So in the US, outpatient can truly mean outpatient or ambulatory, whereas in Germany, there are reasons, both economical as well as cultural, for instance in Korea, where people are less likely to want to go home in one day. You guys are laughing now, and I want to know what the tattoo is too. But overall, I think that there's going to be a drive for ambulatory surgery worldwide. This is data from the US. Again, we see that microdiscectomies, since approximately 2007, more have been done as outpatient than inpatient. And you can see at the bottom of this curve here that the green line is ambulatory surgery centers, which again are also on a growth trajectory. And so that goes for microdiscectomies, lumbar laminectomies, again trending more towards outpatient, although not quite as often as the microdiscectomy. Lumbar interbody fusions, not yet, but certainly if you watch some of the talks on awake lumbar interbody fusions, we may see that someday. And so the other important aspect to this is there's a cost benefit. Some of the people here in the room have put together this, demonstrating that endoscopy is less expensive than the traditional open techniques, at least in some locations. And part of that is because there's not necessarily anesthesia needed for every type of procedure, and that can bring down costs. Minimally invasive procedures like endoscopy, they limit tissue damage. When you really decrease the access and the amount of muscle that you have to manipulate, you have a limited need for anesthesia, and then of course limited complications and readmissions. The access technology is relatively simple. There's endoscope and the associated tools, image guidance technology, which is fluoroscopy, which is available just about everywhere. And then the anesthesia can vary. The anesthesia is general anesthesia sometimes, but as we've seen today, you can do a lot of things under local anesthesia as well as regional anesthesia that can make this a lot less infrastructure heavy. And that decreased anesthesia needs really can also demonstrate improvement in cost. This is showing spinal anesthesia versus general anesthesia. and the overall direct and indirect costs are decreased when using these regional anesthesia techniques. And of course, if you're using local anesthesia, that's going to be even less. And finally, the push towards ambulatory surgery and using these types of endoscopic techniques to get there is potentially going to benefit the overall distribution of surgical care worldwide. Inpatient procedures require a large infrastructure. As you can see in this picture, there's a bunch of stuff filling the frame. There's all sorts of retractors and tools and navigation equipment. But ambulatory procedures require less infrastructure and can be more widely distributed. As a kind of metaphor for this is data from Dr. Ben Worf. He's a neurosurgeon who went to Africa to treat hydrocephalus. And what he found was that although they did have a relatively inexpensive shunt system, which is a way to treat hydrocephalus, that implant was too expensive for most of the population and also had a propensity to fail catastrophically. So he changed his practice and went to an endoscopic third ventriculostomy, which is another endoscopic procedure to treat hydrocephalus, and actually found that was an overall better solution. It was less expensive and lasted longer. That's what the data here is showing, and also was less likely to catastrophically fail, so that the patients could get back to the hospital to get treatment before having any significant complications. Endoscopic technology can definitely be seen as a leapfrog technology, much like the mobile phone in places like Africa, where infrastructure really couldn't keep up with demands, and technology was able to jump over the infrastructure problems of trying to have wired telephone technology. And so along with that, we may see disruptive improvements in imaging technology that would potentially allow endoscopic procedures to be done without fluoroscopy, which again would be another jump ahead in the ability to treat patients with spine problems. And so as an example, this is my daughter when she was in utero on the left, and then also after she was born. You can see how accurately depicted, although all babies look the same, but it looked really good. And this is, of course, very old technology. I had my wife running around the house looking for my son, who's about 5 years younger. The newer ultrasounds give you a nice 3D rendering of your child, so you know exactly how nice, good-looking or ugly they're going to be before they come. So, in conclusion, endoscopic spine procedures allow common spine surgery procedures to be done in an outpatient or ambulatory fashion. This will allow increased access to spine procedures worldwide, and of course in your local institution.